Alright, good day guys. Welcome to my channel once again. This is Dr. Paramount, a go-to destination for orthopedic insights and practical knowledge skills. I have your tutor, Dr. Pastor. Today I will be talking about the management of Colles fracture as one of the topics, as one of the most talked about topic in orthopedic setting. Colles fracture is a very large incident that occur in orthopedic setting as regard fractures, as regard dislocation and some other occurrences in orthopedic setting generally. So when we talk about Colles fracture, basically is a little bit wide, but I'm just going to try to summarize this thing. Colles fracture was discovered in 1814 by Abraham Colles, who came about bringing this thing into existence and study how the fracture pattern came, and he brought about the management, because then the occurrence of Colles fracture were many and it was on the high level compared to other fractures of upper extremity. So when we talk about Colles fracture, basically it happens on the radial bone. Radius is one of the bones of the upper limb, forearm to be precise. So we have ulnar and radius to be the bones of the forearm. So typically radius is said to be the one that accommodates the fractures of this Colles we are talking about. So before we can make a final conclusion on whether the fracture is a Colles fracture or is not a Colles fracture, there are things that must be done. There are things that we must see. There are things that we must notice. There are some clinical presentation the patient must present with before you can conclude that this is a Colles fracture. So Colles fracture is said to be fractured to the distal 1/3 of radius. So when there is fracture to the distal 1/3 of radius, and there is dorsal displacement. So when I'm talking about dorsal, we have something called dorsal, we have something called volar. So as I'm placing my hand, the dorsal is at the back side of the limb here, where the volar is at the front side of the limb. When the patient presents with a fracture of the distal 1/3 of radius, there are two possible fractures that can happen there on the same bone. Distal 1/3 of radius, if there is a dorsal displacement, is called Colles fracture. If there's a volar displacement, it's called Smith fracture. But today, in particular, I'm going to be talking about Colles fracture. So a typical example of it is this bone. This is a radial bone I'm talking about, and the lower end of radius that I'm talking about is somewhere around this place, 2 centimeters or 2.5 centimeters below the wrist joint. So when there's a fracture around this side, it will cause a dorsal displacement, and when dorsal displacement occurs, there's going to be a clinical deformity that will be formed that is called dinner fork deformity. So when a patient presents with a Colles cast, the nature of how the hand will look like will form a fork, dinner fork, that you used to eat in your own house. So when you notice the nature of the hand, that the hand is presenting with something in form of fork, you conclude that this is a Colles fracture in particular. Now, Colles fracture is common in adults and in children. The reason why it's common in adults is because they have brittle bones. Their bones, as they are growing older, their bone is losing mineral, their bone is losing strength. So they are tender to fracture, and also it's common in children. So the rate at which Colles fracture happen is more in adults, and also is more in children because of the nature of the bones they have. In adults, their bone is being demineralized, and also children, they have a growing bone, their bone is still growing. So now when we talk about this Colles, what are the causes? How do these things come to existence or reality in a patient limb, in a particular body? So the first thing that can cause Colles fracture is fall on the outstretch of hand. When I talk about the outstretch of hand, I'm talking about this place. When you are trying to fall down, maybe on a tree, and you are trying to use one hand to defend yourself. So in that particular sense, there is a tendency that thing is going to cause a Colles fracture. When you fall on the outstretch of hands like this, when you fall on the hand like this, there's going to be a displacement. The fracture will happen on the radius, the lower end of the radius, and there's going to be a total displacement. So that's the first thing. Number one, another thing that can cause Colles fracture is what we call osteoporosis. The nature of the bone will be weakened by diseases or any form of thing that can cause the bone to fracture easily. Then the third one that can cause when you don't take calcium, inadequate calcium and vitamin. Alright, so another thing that can cause Colles fracture to occur is there are some work that can actually lead to it when you walk in slow or when you walk in height or any work that is forward momentum. can actually lead to Colles fracture. So, like I said the other time, that it has a clinical deformity that is called Dana-Pop deformity, and it's a very simple to diagnose. When you see a patient that has sustained a Colles fracture, this is one of the ways that you will know that it's a Colles fracture. When you study the bones, the nature of the anatomy very well, and if there's a fall on the outlet of an, this side of the fragment will come up, while this one will go down. So that's why we call it a dorsal displacement. So when you see the patient and it's going to form something we call Dana-Pop deformity. Then another thing that you can use to differentiate between a Colles cast and a Smith cast, because I told you that on this bone, the lower one third of this side, which is on the radius, there are two possible fractures that can happen there. So we can have what we call Colles fracture, then we can also have what we call Smith fracture. I said the other time that when we have a dorsal displacement, at the back here, is what we call Colles fracture. When we have a dorsal displacement at the palm side, is what we call Smith fracture. Now, there is another way, there is another means of you differentiating between a Colles cast and a Smith cast. So, as an individual, if you master the nature of the fracture very well, whenever there is a fracture on the lower end of radius and the fracture displaced towards ulna, so this is ulnar bone, the fracture happens on this side of the radius and it's displaced towards ulna, that's why we say it's a Colles fracture. But when there is a fracture, it happens on the radius and the fracture displaced towards the radial side, that's called Smith fracture. So with these two ideologies, you can actually differentiate between a Colles cast and a Smith cast. One of the ways you can differentiate is number one, Colles cast is a dorsal displacement, while Smith cast is a polar displacement. The number two is Colles cast displaced towards ulna, while Smith cast displaced towards radius. So those are the two ways you can actually use to differentiate between a Colles cast and a Smith cast. But by and large, today I'm talking about a Colles cast. So without wasting time, what are the clinical presentation? When I say clinical presentation, I'm talking about when the patient comes, what are the things the patient is going to present to you as a technician or as a technologist or as a medical practitioner. When you see the patient leave, there are things that you will see the patient will present that will make you conclude that this is a Colles fracture. Number one thing, that will be a Dana-Pop deformity. Like I said the other time, the hand will look like a Dana-Pop. The shape of the hand, the way the hand is going to be presented will look like a pop. So by that, you definitely know that this is a Colles cast. Number two is that there will be history of falling on the outstretch of hand. In patient history, what the patient will tell you when you ask the patient what actually led to the fracture, they will tell you, okay, in one way or the other, you must fall on the outstretch of hand. Or let me take an example. For example, the goalkeeper and you are trying to defend the ball, football right now, and you're trying to defend the ball without putting on hand gloves. So if there's an epic shot that was shot on your hand, if you are trying to defend the ball and the hand was not in the glove, there's a tendency of you sustaining a Colles fracture, just like the way you are falling on the outstretch of hand. So in patient history, there must be a documentation of patients falling on the outstretch of hand. That's number two. Number three, there will be dorsal wrist pain. At the back side here, the dorsal aspect of it, there will be pain more than the volar side here. So with that, we definitely understand that this is a Colles fracture. Another thing is there will be swelling of the wrist. That is normal for all fractures. When fracture happens, the thing that will follow that will be significant is swelling. So another thing is inability to grab any object. So if you see any patient with a Colles fracture, you will not find it very easy to hold any object like this or even like this because of the nature of where you are holding. Another thing that will happen is there will be something we call dorsal communication and there will be dorsal angulation. The hand will angulate to the dorsal aspect of the limb, and there will be something we call dorsal displacement and radial shortening. You know, the fracture happens on the radius, and the nature of the fracture that happens has cut the radius to some extent, so there will be shortening. If the management was not done properly, there will be problem at the end of the day. That's why proper management must be followed in Colles fracture because it's very deadly. So the last one is there will most of the time there are associated fracture of the styloid process on the ulnar bone and the radius bone. There's something we call styloid process of ulnar radius. At this end, this is what we call styloid process of ulnar of radius. this so called stellar process of honor. So when there is a fracture to this radius here, most of the times there are associated fractures of the stellar process of the honor. So this happens most of the times as part of the clinical presentation and the features of Colles fracture. In any of these, if the patient is presenting with any of these as a technician or as a technologist, you discover. So when we talk about the management of Colles fracture management can be done in two forms. You can actually do it conservatively by the application of plaster of Paris cast, scotch cast, and or some other cast that we can use to manage the fracture conservatively. That is non-surgical method. Then we can also use surgical method. So I will be talking mainly about this non-surgical method, which is the conservative management of fracture, which is going to be with the application of plaster of Paris, which includes the technician, which includes the patient, and some other people that will contribute to the management of this fracture. So the management of the Colles fracture conservatively, the way it's going to be done. So the first thing to do is to disimpact the fracture site. So if the fracture is impacted or the fracture is displaced to some aspects, there's going to be something we call disimpact. So we have to disimpact the fracture and let it be normal. So this is how we disimpact fracture. The assistant will be there to do the counterpulling. So the assistant will be exerting pressure on this place so that the bones can be disimpacted. So this is how we disimpact the bone. We place the two thumbs on the side of the fracture. Then we try to pull the hand in this manner. Then the assistant will pull in the opposite manner, which is the counterpulling, and the patient's limb is going to be disimpacted with a full force. Without force, this is not going to be done. So by this, we have disimpacted the fracture, and everything is going to be perfected now. Everything is going to be in line. So the hand has to be disimpacted in this manner. Everything has to be done like this. Now, well, how to measure whether what you have disimpacted is good or whether the ulnar and the radial head are now in the same alignment? There's something you have to do. Having the mindset that we have the radius here, having the mindset that we have the ulnar bone here. So you have to use your finger, index finger, to check something. When you place your index finger here on the stellar process of the ulnar, you place your index finger here on the stellar process of the radius. So if everything is anatomical, everything is balanced, there should be, the radial side should be 1 centimeter ahead of the ulnar. So if my hand is like this, if the stellar process of the radius is here and everything are the same like this, that means we have not gotten the normal reduction. We have not gotten the normal alignment. So if it is normal thing, the radial styloid should come ahead 1 centimeter ahead of the ulnar styloid. So it should be in this manner. So like this, you must have gotten an assurance that your alignment is proper and it is good. So the radial styloid should be 1 centimeter ahead of the ulnar styloid. So after this, there's something we now go to the aspect of the reduction, because you have to reduce it before applying the plaster of Paris. So the first thing we do is we do the palmar flexion, followed by the ulnar deviation. Why do you have to do ulnar deviation? Because I told you the other time that whenever the fracture happens, it has to displace towards ulnar before you can call it a Colles fracture. So the fracture displaced towards ulnar, we have to do something called ulnar deviation by pulling the bone away from the ulnar. So we do something we call palmar flexion and ulnar deviation. So this is, at the end of the day, we must have the hand like this. The assistant is exerting pressure on the opposite, which serves as the counterpulling, while the hand is going to be maintained like this. Like this, there is something we call ulnar deviation here. The radial head has been shifted. The radial side has been shifted away from the ulnar side. Then we have the hand to be maintained like this. So after something like this, we have to lock the casting. We have to lock the reduction by putting the hand on it for some minutes, maybe 2 to 3 minutes. After that place has been locked and has been achieved, that's when we proceed by applying the autobahn from this end down to this end. We stop at either you start here, you end here, or you start here, you end here. But anatomically, if you want to start, you start from below the metacarpophalangeal joint. You apply it above. When you are done with your padding and your POP, you turn back the padding material before you apply the last layer of the POP.
You apply your padding, then you apply your POP. After applying the first layer of the POP, you have to use your hand to position the cast very well. After applying the first layer, before you apply the second layer, you have to use your two hands on the fracture side and hold it very well. You hold this hand like this. By that time, this hand must have been held in this manner because of the POP. The shape must have been gotten. Then you use your hand in this manner to straighten this place so that it can form to the contour of that particular shape you want to bring. Then after that, you apply the second layer, apply the third layer, if possible apply the fourth layer, then you do your normal proper cleaning. At the end of the day, the hand must be positioned like this. So we have a little flexion of the palm, and also we have ulnar deviation. The reason why we do the ulnar deviation is just to make sure the fracture end is shifted away from the ulnar so that we can have a proper reduction. And having done this, we have to confirm our reduction by following the radiography. We check the X-ray whether the reduction has been done perfectly or not. So if the reduction has been done perfectly, you discharge your patient, or you place your patient on admission maybe 24 hours to check if there's any issue, maybe swelling at the end of the day, or any problem that can arise. If the X-ray is not perfect, then you have to do the casting again, then do the reduction again, start from the disimpacting the bone, then do the reduction, ulnar deviation, palm flexion. So at the end of the day, we must have something like this. So this is a typical management of Colles fracture, the conservative management with POP or scotch cast or any material that you can use to immobilize the fracture without doing surgery. Like I said the other time, there are also methods that you can use, surgical method. That's why you do open reduction and internal fixation with the help of plate and spear and some other surgical materials, surgical procedure. But that's not what I'm talking about here. I'm only majoring on the conservative management of fractures. So this is the brief method of managing Colles fracture with a cast, POP, scotch cast, and also some other materials. Like I said, Colles fracture is when there's a dorsal fracture to the lower end of radius, 2 cm, 2.5 cm below the wrist joint. Then it is displaced dorsally, or it is displaced towards ulnar. And I told you there are 2 fractures that happen on that same end of radius. One is Colles and the other one is Smith, and you can manage it conservatively. I haven't talked about the causes, that it fall on the approach of hands and everything, the clinical presentation, the features, and the management. So this will be the ending part of the lecture. Feel free to go over the lectures again and just try and get what you need to get on the management of Colles fracture as far as conservative method is concerned. So in my next lecture, I'll be talking about some other fractures and how we can deal with those fractures conservatively with manipulations, with POP, with backflap, with collar and cuff, with any form of materials that we use to manage it conservatively. For now, guys, do well to subscribe to this channel, do well to like, and make sure you click on the notification bell, because this will give you an instant notification. Anytime we drop new video here, you'll be notified immediately so as to get proper knowledge on the conservative management of casting. Because it is only on this channel I tell you about the fracture management conservative. So don't do without subscribing, and don't do without commenting, liking, and sharing. So in the next class, I'll be talking about some other things. See you there.